This podcast is sponsored by CSMI, the maker of the HUMAC Norm isokinetic system. Purchase a new or refurbished machine, or you can even upgrade an existing system to bring it up to date with all the latest testing and training applications. Please visit csmisolutions.com to view all of their available products, including the HUMAC Norm isokinetic system, the HUMAC Balance portable computerized balance system, and Sportswear Online. CSMI. Better data leads to better results.
The Everything PT podcast is sponsored by Vald Performance. Vald is the creator of the airbands for blood flow restriction therapy. If you are looking to stay up to date with today's post-surgical modalities and adding BFR to your clinic, please visit valdperformance.com. Hello, and welcome to the Everything PT podcast with Matt Taylor and Daniel Bodkin. Please do not consider anything you hear to be medical advice. Just a couple of guys ranting about everything PT. Enjoy the show.
Welcome back to the Everything PT podcast. My name is Daniel Bodkin. I'm joined by my co-host, Matt Taylor. Matt, what's going on?
Dan, hey, not much, man. Just got out of the emergency room. I didn't tell you that off there a couple days ago. Thought I might have had appendicitis, but everyone, I'm okay.
Wow, interesting.
Yep, it's the most expensive bag of IV fluids I've ever had. So.
Well, speaking of emergency room, we decided we were actually going to talk about something else today, but then we had an unfortunate event take place on Monday Night Football with Damar Hamlin. Had a midfield tackle, collapsed on the field, and so I wanted to talk about that a little bit today. And I know a little bit about this subject, being an athletic trainer. I know enough to say things and be wrong about it. So I thought we'd bring in an actual expert on the subject.
I think it's a great idea. I have no athletic training background, so I know even less. My wife is a perfusionist, so I know she was spouting off about some of the things that have happened too. But yeah, I'm excited to get to our guest here.
Yeah, so today we're joined by a board certified cardiologist, Alex Sommerfeld. Alex, how's it going?
Good. How you doing, guys? Thanks for having me on.
And I'm all about disclosure, so I just want to let everybody know. Alex and I have a pretty big thing in common. We actually married a set of sisters. So Alex is my brother-in-law, and so we live in the area together. We see each other a lot, and he's the first person I thought of when it came to having a guest on. So Alex, let's talk about the situation that happened.
Yeah, absolutely. So, big football fan myself, was watching Monday Night Football, and definitely on the replay, immediately knew based on the hit that I did not think anything neurologically was going on. The contact was directly to the chest. And then seeing him stand up made me realize that, well, one, he's neurologically intact. Someone that has had a spinal cord injury is not going to be able to get up off of the ground. But so immediately when I saw him basically collapse to the ground, I knew something was wrong. The question was certainly, blunt trauma to the chest, what I was thinking, but certainly there is a very rare but reported known cause of sudden death. Now, at the time, did not know, was he pulseless, was he not, until they were talking about CPR, but certainly was concerned that something was wrong and did think it was related to trauma to the chest. Certainly, blunt trauma can cause issues to the aorta itself. So any, the main vessels of the heart. And so thinking about aortic dissection or rupture of the aorta were things that, you worry about, but certainly upon kind of as things evolved, one of the common differentials in that sort of situation would be commotio cordis. Certainly there are other things that can cause people to have sudden death or have syncope during exercise. And in general, syncope with exercise is, for any athletic trainer or for any therapist, or anyone involved in sports in general, an athlete that passes out on the field is always a red flag and should be a hard stop to seeing a cardiologist and getting further evaluation. But commotio cordis is sort of it's a rare cause when basically direct trauma, mechanical forces to the chest wall, timed at a certain point in the cardiac cycle, can essentially stun the heart at a point when it's vulnerable to causing an arrhythmia, which can cause a person to pass out or have what we call cardiac arrest. And the specific type of arrhythmia that you worry about is what's called ventricular fibrillation, where essentially the heart is quivering. There are these electrical cells in the heart in the ventricle that are basically fibrillating, and that is not a normal mechanical way that the heart should pump out blood. And so basically blood does not effectively circulate to the body, and that's a life-threatening arrhythmia. Usually requires defibrillation to stop it, and certainly CPR to temporize until you can shock an individual, a patient, is what you have to do. Most commonly, commotio cordis is reported actually in younger individuals, usually and typically males, young males. A couple reasons why. So underdeveloped chests is one of the reasons why. So as you mature, your skeleton, your thoracic cage in general, the ribs, the cartilage become less elastic and stronger. Bones actually become stronger as you age into puberty and young adulthood. So younger individuals, young kids, young male boys tend to be most commonly affected. And it typically involves a projectile, so a baseball, a hockey puck, getting a bat to the chest. And that's largely because a smaller surface area is delivering more mechanical force into the area of the heart where it's vulnerable. Typically, probably most commonly at the kind of apex of the heart, where the heart's kind of closest to the chest wall. So if you think about the midclavicular line, probably a little bit further out laterally would be where you are most concerned about the trauma there. But, in terms of the incidence of that per year, I think exceedingly rare. I think, Danny, you were even going to comment on some of that, if I'm correct.
Yeah, it's rare, but it's common enough that we discussed it in length when I was in school at USF in their athletic training program. Now, granted, we had a couple cardiac incidences. I would love to talk about obstructive cardiomyopathy, maybe, if we have time for it. But we had an incident where an athlete, one of our football players, was exercising in the gym and had sudden cardiac arrest. Unfortunately, with that, they applied the AED, but that's not one where you can restart the heart because it's more of an obstructive issue. We also had a young lady who had long QT syndrome, the same thing, sudden cardiac arrest on the softball field. They were able to resuscitate her and get her with the AED. So USF was really big on their cardiac emergency response. So I don't know how other programs covered it, but commotio cordis was something that was definitely we knew about. And like you mentioned, it's a lot with youth sports. And you see it a lot with soccer, hockey, even, punching, kids, boys love to sit there and punch each other. So it is more in those youth sports. Now, thankfully, it was the NFL. They had, their athletic trainers, their medical response team was there right away. They had an AED, they had ambulance. Think about this. If you're covering an event, let's say you're a PT and you're actually out there, with a team covering it, or if it's just your kids, out there playing in the cul-de-sac, one of these things happens. You don't have that kind of equipment right there readily available. So what's the time frame we're talking from, the person going down until, they get that defibrillation? How much time are we talking that you have?
So, that's a good question. Certainly and most commonly the direct impact will then stun the heart and cause the person to go into that arrhythmia. So, my suspicion is probably, and certainly this is sort of in the algorithm of ACLS and basic life support of, when you have an unresponsive and unconscious patient or individual that you've encountered, the first thing you should try to find is their pulse. Mm-hmm. So a pulse check is really crucially important. Give yourself 10 seconds, try to find the pulse, try to see if they're awake and able to respond to you. And at that point, if they're not, then the guidance is to immediately start CPR and call 911. Mm-hmm. If you're by yourself, the guidance is call 911 and then start CPR. Not everywhere are you, given the luxury of having an AED on hand. Not every kind of cardiac arrest is going to require defibrillation. So that's also sort of in the algorithm. So depending on the kind of arrest, an AED may or may not be what you need, but certainly what we know saves lives is early chest compressions, and when applicable and appropriate, early defibrillation is probably what saves the most lives more than anything. And I think it certainly is a sort of a calling or this is a good public service announcement, for everyone. You don't have to be a doctor. You don't have to be a nurse. You don't have to be a pharmacist. You don't have to be an athletic trainer. You don't have to be a physical therapist. Every citizen can learn how to do CPR and learn how to do it effectively. And you can save lives. Speaking from firsthand experience with patients that have survived out of hospital cardiac arrests, and one patient that was collapsed on a tennis court after 2 hours of tennis, had immediate bystander CPR started, walked out of the hospital completely neurologically intact. And so There's no doubt about it, starting early CPR and early recognition saves lives. For every minute that you delay CPR or deliver ineffective CPR to provide adequate perfusion to the brain, the most sensitive organ in the body, and to other organs as well, your likelihood of mortality, your likelihood of death increases 10% per minute.
Whoa.
So early recognition is important.
Alex, just a quick follow-up question here. In my own preparation for this, I looked up commotio cordis. I must have been asleep when we went over that in grad school, because I had never heard of it. But I found that there's 30 reported cases annually, which is, it seems pretty rare. What about you specifically? How many cases have you dealt with in your professional career?
Great question. So, I'm relatively fresh out of my cardiology fellowship, a couple years out. I remember hearing about it once in 3 years of fellowship, and I have never encountered a patient with commotio cordis. Full disclosure, I'm not a sports cardiologist. That is sort of a little niche area within cardiology, sports cardiology. It's like we've said, it's certainly a dreaded and feared condition. It's well reported and documented. But in terms of, if we looked at the overall prevalence of sudden death in athletes and sudden death in the population in general, but certainly sudden death in competitive athletes, commotio cordis would be lower on the scale. Other kind of presentations, that we certainly see would be something like hypertrophic cardiomyopathy. The other common thing that we certainly see are congenital arrhythmias, so long QT syndromes. Brugada is another kind of phenotype of a mutation in a certain ion channel in the heart that can result in ventricular arrhythmias and sudden death. The other one used to be thought more common, but now felt to be less implicated, but certainly can cause sudden death, are what are called anomalous coronary arteries, particularly if there's an anomalous left main or left coronary artery. So the coronary arteries, I actually have even a little diagram here, originate off of the aorta, but if they course off of an abnormal cusp, they can actually course in between the two great vessels, the aorta and the pulmonary artery. And so during exercise, when you have increased stroke volume and volume going through the chambers and more, your blood pressure increases normally physiologically with exercise, the artery can actually get compressed in between the aorta and the pulmonary artery, and that can be a cause of sudden death in athletes. So a congenital anomaly, but nonetheless another cause of why individuals can have sudden death. But without question, arrhythmias, structural heart disease, particularly hypertrophic cardiomyopathy, anomalous coronary arteries, very common causes for sudden death, and certainly more common than commotio cordis.
Mm-hmm. Yeah, I was listening to Jeff Cavalier of AthleanX talk about it today, and he was saying if you looked at how many contacts, whether it's a tackle, hitting the ground, you tackling somebody in football, just pro football, not to mention college or high school, if you look at how many contacts occur in just a game or a practice across the league, right, per week, across the year, across the decade, you're getting, hundreds of thousands, if not more. He actually threw out some stats of, possible contacts without ever having this come about. So it is extremely rare. We mentioned HCM, hypertrophic cardiomyopathy. I think that it's found to be about 1 in every 502 people. And it was pretty interesting because USF started doing stress echoes as part of their screens, their cardiac screens of all the athletes. And this is after that instance occurred. And we actually found, they identified 1 out of 502 athletes that they screened. It was kind of odd that it matched up perfectly, but it was just like a poster presentation that I was part of, but it was really interesting how it ended up being the exact number. Mm-hmm. And so you have 1 out of 500 people walking around with this, but they're not at the level to where their heart has hypertrophied like an athlete will. So, you or I may have it, but I'm never pushing my heart to where it's going to naturally get bigger and stronger to get that obstructive aspect to it.
And the other interesting thing, hypertrophic cardiomyopathy, it's a very interesting disease process. One, there are probably hundreds of genetic mutations that result in hypertrophic cardiomyopathy, and there are, HCM in general can have an extremely heterogeneous phenotype, meaning, it's not a one-size-fits-all disease. In HCM, for some people, it involves the apex or the most distal portion of the heart, and other people it can involve more of the basal septum. So there's a number of different phenotypes. Some will develop obstruction, some will not develop obstruction. It is not necessarily something that manifests itself in a symptomatic expression until certain points of someone's life. So someone may not develop that hypertrophy until well after their athletic careers. Yeah. Into their 40s or 50s. We do see that, sometimes even as late as 60. Most commonly, usually after puberty. But absolutely. HCM can have a very variable phenotype, degree of symptoms, degree of what we call outflow tract obstruction, and the location of the hypertrophy can also be pretty variable. Needless to say, all those patients that are diagnosed with HCM do require what we call further risk stratification to assess for obstruction. And what we mean by obstruction is basically the thickening of the septum of the heart becomes so thick that it impedes the ability for blood to get out to the main vessel of the heart, the aorta. And so if there's significant obstruction, enough blood can't get out, people can pass out or have sudden death. And certainly when you're exercising, your heart is squeezing harder, your blood pressure is going up, and all of those things can sort of precipitate to cause that kind of what we call dynamic obstruction. Yeah. So doing exercise, stress testing, having these individuals that are eventually diagnosed with HCM, wearing heart monitors, because irrespective of the outflow tract obstruction, they can also develop arrhythmia. The way the architecture of their myocytes, the muscle cells of the heart, is very disorganized. And that can lead to, in certain individuals, arrhythmia and scar. And so some of these individuals will get MRIs. All of these individuals should require at least a 30-day Holter monitor to see if they're having arrhythmias. We also look at family history. there's a family history of sudden death. These are then criteria where you may even require a defibrillator. The good news is in commotio cordis, and of course I don't have all the details for Damar, but if everything is in line with commotio cordis, and certainly in the ICU where he's at, I can guarantee you they're going to be doing an onslaught of testing, including an echocardiogram, trending labs. If there aren't any a baseline EKG, to make sure that there aren't any other things that would point to something else. But I think everything at this point is clearly saying that this was commotio cordis. Again, not having access to all the records, but for certain, there will be an onslaught of testing done for him. And I have to say, in general, in regards to for the NFL and for competitive collegiate athletics, and I think you can comment on it too. There is a good amount of screening that is done to try and identify these things. And so commonly, like with hypertrophic cardiomyopathy and long QT syndromes, a baseline EKG and a stethoscope in general can be profoundly helpful. And I can assure you that all of these collegiate athletes and NFL players are getting that, those screening tools each year: EKG, a history, and physical examination.
Question real quick, Alex. So say that, Dan, 1 out of 502 student athletes to screen, say we find one, which is great. That's a win. What now? What now for this student athlete?
Excellent question.
How do we safely get them to participate?
Excellent question. The goal, our goal is to safely get them returned to play, if feasible. The next step is, they need to see a cardiologist. Ideally, I think best suited for someone that has, and certainly starting with the general cardiologist, and in even more complicated cases, there are centers of expertise for hypertrophic cardiomyopathy. But needless to say, starting with the general cardiologist to start the initial workup of all these things and getting them further risk stratified to figure out, one, are they safe to compete in athletics? That involves echo, monitor, exercise, treadmill testing, and certainly in more complicated cases, either a sports cardiologist or an expert in hypertrophic cardiomyopathy.
Now, there's one last thing that I want to add to this. And that's, I've been hearing a lot of talk on, YouTube or social media or even the news about the response, the initial response on the field. And, there's been a lot of praise for them, but I was hearing, why did it take them so long to recognize what the situation was? Why were they spending so much time, holding the head in their response? And, my thing of that is, as viewers on TV, we have the luxury of having that instant replay, of having all those different angles. The athletic trainers, the medical staff, when they're on the field, they don't have those angles. And you got to understand how many people are actually out on the field, so you can't see every hit. And even the ones that you do see, you're seeing it from across the field and at a different angle. So keep that in mind, that when you firstly see this, you got to initially think cervical spine. That's something that's got to go through your mind. So you go out there and you got to stabilize that the neck, and then you're doing your assessment. You're looking at pulse, at breathing, and even if you've taken a CPR course and you practice, finding that pulse, it's difficult to find. Throw on top of that the anxiety, the stress, the adrenaline that's going through you. I mean, your own pulse, your heart rate's going to be pumping. You have the sound of the crowd. So you have all that going on. You're not exactly able to ask the athlete what's going on. He was unconscious. Also think about the pads. You have all this equipment. You have a face mask that has to be removed without, compromising the cervical spine. If you do take CPR, we always learn the head tilt, chin lift. But again, in a contact sport like football, you can't just assume it's not the cervical spine. So you have to do a different jaw thrust maneuver. Other things to think about are the equipment, the shoulder pads that he has on. So just getting to the athlete's chest to apply an AED for it to analyze your rhythm is much more difficult. And thank God that they did an excellent job on the field. But these are all things that if you're just either, you're covering an event and you're by yourself, or just, you're at your kid's, a high school or, middle school game, or even just, my kids playing out in, when they play with their friends in the neighborhood. These are all things that it's really easy to analyze when you have that video replay, when you kind of known about it, having that hindsight. But just keep a lot of that in mind as, this team, those first responders, those athletic trainers did a fantastic job given all those different circumstances. And so I really want to, praise the hard work and the training that they've done to be able to have this kind of an outcome for this athlete so far. All right. Well, Alex, thank you so much for coming in and talking to us today. And, it really brings a lot more. It's one thing for me and Matt to sit here and talk and speculate, but having that expert, someone that with a lot more knowledge about it is very helpful. Alex, if anybody has questions that they want to contact you, how can they get a hold of you?
Yeah, great question. I would say probably best through my personal email account, which I'm happy to give you guys. It's just asummer4@gmail.com.
Awesome. Yeah, we'll include that in the description of the show as well. Well, thank you again. I know hopefully DeMar continues to recover. I saw just, a little bit ago, he's starting to show a little bit more improvement, requiring less oxygen. So we really hope for, the best possible outcome for him. And then any kind of awareness that this could raise, if somebody, whether it's this podcast or listening to other people talking about it, can, go out and learn CPR and then save somebody's life in some way from that. Hopefully there can be, only good outcomes coming out of this.
Absolutely.
Yeah.
Thank
Thank
you
you
guys
for
for having
coming on
me.
the show. Thank you for coming, Alex.
All right.
All right. Thanks, everybody. We'll see you all next week.
See you guys.
Looking for a way to improve sport-specific training with your athletes? Then you have to check out Blaze Pods. Blaze Pods is a neurocognitive reaction training intervention that can be incorporated into your sessions for patients throughout the treatment spectrum. Visit blazepod.com. Enter code EVERYTHINGPT at checkout and save 15% off your order today. Hey, all you rehab specialists out there. Do you have an isokinetic dynamometer just sitting around your clinic not being used? Little known fact, isokinetic machines that aren't used regularly are at higher risk for bouts of sadness. Help your machine out and take CSMI's newest CEU course, Isokinetics 101 online, created by me, Daniel Bodkin, and learn how to use all the exercise and testing applications available on your machine. With new and exciting rehab techniques in your toolbox, your sad isokinetic machine can become an active member of the rehab team again and regain its happiness. Isokinetics 101 online by CSMI has been approved for 8 credit hours for athletic trainers, physical therapists, and physical therapy assistants. Contact your state board for details on specific requirements. This course is available at humacnorm.com/courses/isokinetics-101.